Okay, so I'm not quite sure how long you want me to go on, and the first email I got from Julie was to talk about fertility and pregnancy. So I have a great talk about fertility and pregnancy, but then a week or two ago, Julie said, actually, that may not be the interest of the attendees on the call. So I'm not going to talk about fertility and pregnancy, but if you want to talk about fertility and pregnancy, I'd be very happy to. But so I was given a little bit of a broad brief. And, you know, believe it or not, we often find it quite difficult talking to patient and carer groups because we spend all our time talking to doctors and trying to actually tune in with really what you're interested in and want to know about is often quite different to what we're normally talking about. So I apologize if things occasionally veer off out of the straight and narrow. But in terms of who I am, I'm a doctor. I work at Addenbrooke's. Addenbrooke's is based in Cambridge, and it's becoming a huge campus. This blue hospital here is our new heart and lung hospital called Papworth, and this sort of building here is the new headquarters of a drug company, AstraZeneca, which has arrived right in the middle. And this building here is one of our big laboratories in molecular biology, where monoclonal antibodies were first made and so on. So it's a big, big campus. And the vasculitis clinic started there about 1987, and I was a junior doctor there at the time. And it was started by my supervisor called Martin Lockwood. And then I took over in about 2001, as I say, having been in South London, and have been there ever since. So what I was going to do is just bring out three themes, and I hope you find some of the points interesting, and then leave some time for your questions and discussion at the end. I'm going to talk a little bit about the words that we use, because the language is quite a barrier to understanding this field. Talk a little bit about patient care, and then finish talking a little bit about some new drugs. First thing to say is I was very sad to miss the meeting in Dublin, and I know Julie organised a very good meeting at the beginning of it. This was an International Vasculitis Congress, which was really the first time the community had come together. And we do have a sort of professional group called UKVAS, UK and Ireland Vasculitis Group. And we had our first sort of residential training course in Cambridge just before Christmas, and it coincided with this huge snowfall. And the trains all stopped, but I'm glad to say everyone managed to get there except the delegates from Ireland, because the flights were all grounded in Dublin. But it was a pretty picture of the college where we held the meeting. So what is vasculitis, patient care, and what's new? So I imagine some of you will recognize this photograph, although it's really quite old now. But if you ever watched House, you will know that the terms Wegeners and Kawasaki and Churg-Strauss appeared quite frequently in the text. And actually, the producer of House was a supporter of the Vasculitis Foundation in America. And he was keen to promote public understanding of vasculitis. But the impression it gave was vasculitis was a difficult diagnosis that was often quite obscure to many people. And I think the big change in the last 20, 30 years is it has moved from being small print to being more center stage, and medical students and junior doctors are now slightly better informed than they used to be. But when we talk about vasculitis, we really talk about which blood vessels in the body are involved. Are we talking about the big blood vessels that we can see? The red here is arteries taking blood to the tissues, and blue veins taking blood back to the heart. Are we talking about what we call medium-sized vessels? So these are typically 2, 3, 4 millimeters across, so they're visible, but they're quite small. Or are we talking about tiny vessels, microscopic vessels, which we can only really see down the microscope? And that's typically what you see within the little filters in the kidney, for example. And different types of vasculitis, so different words, tend to affect different sized blood vessels. And I apologize for the complexity of this picture, but this is supposed to be a big blood vessel. This is a little blood vessel and in between. And these are all the words that we talk about. But most patients fall into this group called ANCA, the ANCA group, or they fall into this group called the giant cell arteritis group. Those are the really common ones from our point of view. The others are less common. And as part of this initiative, when this trial was designed, we changed the names. This took place in a hotel in Atlanta, and we changed the name of Wegener's to granulomatous polyangiitis, and eosinophilic granulomatous with polyangiitis, the new name for Churg-Strauss. We also changed the name Henoch-Schönlein purpura to IgA vasculitis, but that's sort of been a bit less popular and hasn't been so successful. After or maybe before or after, anyway, we met in the house of one of the nephrologists. I think this guy here, Charles Jeanette, who had a nice house outside Atlanta. And this was the group of people who drank quite a lot of wine before we drafted this sort of consensus of what all the words were. Believe it or not, if you don't get the words right, you don't talk the language, it's really hard to make progress with research. Okay. What's happened sort of since then is, having sort of agreed, and this might seem very simple, what is one word and what is another word? The next thing that we've done is to try to work out how you can differentiate a patient with vasculitis from one name to another name. And the way that we did that was to collect 6,000 patients in this initiative called DC-VAS from all over the world, along with a couple of thousand patients who did not have vasculitis but had some similar type illnesses. And we looked at all of the different things that were wrong with them, and we came up with sets of criteria that allow you to say this patient has GPA, this patient has eGPA, and this patient has MPA. Again, this might seem a very small or pedestrian step, but if you're doing research, you need to be precise and you need to be able to carefully categorize people in the right places. And all of this has only just come to publication in the last few months, these classification criteria. So, often one of the questions we're asked is, why did this happen to me? What is the cause? And we did the first big genetic study in ANCA vasculitis about 10 years ago. It's published in about 2012. And when you do these studies, what you do is you collect together as many patients as possible. Here it was about 2,500 patients. And then you compare it to about 50 or 60,000 healthy blood donations, which are all collected in these big genetic banks. And then you put the whole thing through lots of complicated tests, and you try to work out whether what are called variants of genes. So for every gene, we have about 27,000 genes, and for every gene there can be different variants, whether variants of genes are associated with disease. Now you have 22 chromosomes, so that's why this goes from 1 to 22. And this is called a Manhattan plot. Somebody imaginatively thought it looked like New York at night, but there we go. And these red dots are genes or variants of genes which seem to be associated with vasculitis. And the ones we're interested in are the ones very high, because the higher they are, the bigger the difference is from the normals. And what we've learned, well, firstly, we've learned that there is a genetic basis to some of vasculitis, and it accounts for about 50% of the cause. That means that 50% is not genetics and 50% is something else. And that essentially is anything that happens to you after you've been conceived. So 50% is genetics, and it's not one gene. So when you talk about genetic diseases, you think about things that are like inherited through families, and those are single gene disorders. These conditions are much more complex. It's multiple genes. But the other benefit of doing these sorts of studies is you can actually get some ideas for new treatments, because you can find genes that are misbehaving, and that can may give you an insight into developing new drugs. So that's sort of where the genetics are at. More recently, we've had genetics in giant cell arteritis, which tell a similar sort of picture, but different genes. So moving on to say a little bit about looking after patients. And I think the first thing to say is, we're not particularly good. We tend to focus very much on the drugs. We tend to focus very much on patients with active vasculitis. And that's, because it's bad. And if you don't stop it, it could potentially get really bad. And then once we're over the sort of acute bit, we tend to slightly, I won't say we lose interest, but we tend to slightly lose depth, should we say. So when we try to think about what patients suffer from, we try to break it down into these sort of categories. So patients suffer from episodes of active disease. We call them relapse when they're quite unwell. They suffer from organ damage. So, for example, their kidneys could be damaged, their lungs could be damaged. This is something that won't get better. This is something sort of permanent and has consequences. They suffer from what we call comorbidities. So these are things that are sort of related. You wouldn't probably have got them if you hadn't had vasculitis, or they're much more common if you do have vasculitis. And they're things like infections, cancer, cardiovascular disease, and blood clots. Having said that, cancer now is much less of a worry than it used to be. It used to be a big worry because of the cyclophosphamide, but really in the last 20 years, we're using much less cyclophosphamide, so it's much less of a concern. Then perhaps less of a worry to patients, unless you're paying for your healthcare, is the costs. And these costs are really considerable and becoming increasingly important to try to understand, because with newer drugs, there's this cost-benefit analysis. Then there's quality of life, which unfortunately remains depressed and impaired for really the majority of vasculitis patients. And there are some reasons for that we understand, but there are many reasons for that we don't understand. And then there's drug toxicity, which you have suffered from, or many patients have suffered from, and clearly is a challenge. So these are the sort of the way we break it down. And in terms of research, we try to break it down into these sorts of areas. So most research focuses on drugs to try to sort out the acute bit. We're beginning to think about ways to try to reduce comorbidities. But quality of life is really a challenge, and so on. So in Cambridge, we've given some thought to how you deliver care to patients, and we have produced some work on this, but we receive referrals from patients from around Britain and some international referrals. We think the specialist nurse has a key role in sort of coordinating everything. We have our own outpatient clinics, clearly, and we actually have an inpatient service. At any one time, we have about 6 patients in the hospital with vasculitis in Cambridge. And then we have active research groups and education. They're all sort of linked together. But if you look nationally, unfortunately, there's no good structure for caring for patients with vasculitis. And because some patients go to a rheumatologist and some go to a nephrologist, it can be particularly fragmented. We think that this should change, and the patient should be in the center, and the specialties should all be around the outside. And this is the sort of model that we're trying to push towards in Cambridge, and it works better or worse for some specialties than others. But essentially, our view is that the doctor directly caring for the patient, it doesn't matter which specialty they've come from, that they're a vasculitis doctor, but they're linked to all of these other specialties to get advice and support the patient. So that's our sort of concept. The problem is this only really works in a big hospital, which has the resource to care for a lot of patients. So it's not going to be something you can replicate in multiple centers, but maybe 1 for every 2, 3, 4 million of the population. So just moving on to patient care, every few years, we collate all of the research that's been done, and we publish what are called recommendation statements. So these are basically a sort of noddy guide to how to treat vasculitis. It's not like a cookery book, but it's like, if you manage patients with vasculitis, you should certainly read the most recent recommendations. And EULAR is a big European organization, which is a very good tradition of producing these sort of guidelines. And this is actually our third cycle of guidelines for ANCA vasculitis, which are just about to be published in about a month or so. They come out about every 5 to 7 years, and they're free to access. Anyone can look them up and download them. And they really try to keep everyone up to date with what's going on with advances. But again, it's another opportunity to meet. This was a very grey and rainy day, but we met in an old castle in Germany, somewhere near Stuttgart, I can't remember, and spent a day or two drafting the guidelines. So I just wanted to say a word about research, because without research, we don't make progress. We don't push things forward, but research takes a very long time. And I just wanted to give you an example of this trial, Pexivas, which we conceived in 2007, I think. And it was really a trial to look at plasma exchange, which is a treatment we use particularly for patients with severe kidney problems. And just to show how complicated these things are, it took us about 3 years to sort out the money. And we ended up getting money from a government in the UK, from America, the FDA, from Canada, from Australia, from France. And we put all these government agencies together to fund the trial. And then we put about 120 centers around the world to do the trial. And the trial took about 10 years. So life is, things grind forward slowly. We've also, within the same study, looked at steroids. Believe it or not, although you may all have been on steroids at one time or other, they've never been formally assessed in terms of what dose you should use in vasculitis, yet they drive a lot of the side effects and problems that patients have. So part of Pexivas was to look at steroids, and we looked at different steroid doses, and we showed that if we actually gave less, so that's reduced dosing, compared to what we normally do, so-called standard dosing, patients actually did fine in terms of controlling the vasculitis, but we saw fewer serious infections. And that meant that we could recommend to everybody they use the reduced dose steroid regimen. So this is actually, again, it sounds simple, but this is the first time we've had what we call evidence on which to base our guidance about steroids. So patients with the most severe vasculitis, this is a filter in the kidney, which is basically full of stuff it shouldn't be full of, so it's not looking very happy. And this is a chest X-ray with lots of white where there should be black. The question was about, do you plug people into this machine, which is called a plasma exchange machine? How this works is it takes blood from the patient, it separates the watery stuff, what we call the plasma, from the cells. It returns the plasma back, returns the cells back to the patient, along with a so-called plasma substitute. And anything in the plasma that's harmful to the patient gets removed. And so it's really designed to remove antibodies, because we think antibodies are part of the problem, at least with ANCA vasculitis. And as a result of Pexivas, we tested plasma exchange, and we demonstrated an effect, but not a huge effect. And then a subsequent report was produced, which I was independent of because I was one of the investigators on Pexivas. So I had to be not in the room while they came up with this. But they basically say if you had a high risk for kidney failure, this is the risk of developing kidney failure. If it's quite high, that is greater than 25%, or at least 7.5 to 25%, then they suggested using plasma exchange. Whereas if you didn't, patients with a low risk, they suggested you should just have standard of care without plasma exchange. So this is just an example of how medical research trundles forward. Get the money together, get the centers together, invite your patients to try to help you do the research, you do the research, and then you give all the information to a whole lot of other people who decide whether or not to change practice. One of the other more recent revolutions has been this drug rituximab, which we actually call vitamin R because it's used in so many areas of medicine, but it's a newer drug. It's the MAB, the MAB bit. It suggests it's a monoclonal antibody, which is a new type of technology. And it has been revolutionary, and it's helped a huge number of patients. But one of the problems with rituximab is that it can cause so-called immune deficiency. That's why I'm putting the two-edged sword. And this just shows over time the proportion of patients who start running into a problem with their healthy antibodies declining, which affects around about 40% of people, not all people, and some people this is only mild and has no consequences, but it just tells you that pretty well any drug does have potential downsides, and trying to understand the upsides and the downsides and get the balance right is what we spend a lot of time doing. Now, I mentioned about quality of life, and often in trials, we assess quality of life by asking patients to fill in a questionnaire, which has a number of questions about how they feel, how much they can do, what's their social interactions like, and so on and so forth. And then we compare treatments to see whether one treatment is better at quality of life improvement than another. And there has been never been a drug in vasculitis that improves quality of life compared to another drug, except for this new drug called avacopan. Now, I apologize for this complicated slide, but basically the point about this is that going up is good. So the more you go up, the better the quality of life is improving. And anything more than about 1 or 2 points going up is sort of important for a patient. And the gray is patients who didn't receive avacopan, and the red is patients who did receive avacopan. And the numbers, don't worry too much about the numbers, but the message here is this avacopan drug really made people feel a lot better compared to the standard treatment, which here was steroids along with cyclophosphamide. And this to me was quite a remarkable result, because as I say, rituximab has no effect on quality of life and no other drug we did. So it sort of validates using quality of life as a tool, but it's also very real for patients, because this is them telling us how they feel. In terms of comorbidities, we've really been derailed by COVID. We had a number of studies set up to try to look at infection, look at heart problems, but that's rather been, and for the last 3 years, we've all been COVID doctors. And of course, vasculitis patients have really struggled through the pandemic for many, many reasons. And I'm glad to say it's all sort of looking good now. We're seeing very few problems in vasculitis patients, but we have had a bit of a COVID deviation. So I'm just going to close really by saying a little bit about the newer drugs, and I apologize for lots of long names, but I want to get over the impression that really after many years, vasculitis treatment hadn't changed much between the 70s and the early 2000s. It was steroids and an immune suppressive such as cyclophosphamide, azathioprine, methotrexate. And that hadn't really, in fact, those drugs were really first introduced in the 60s, and they hadn't really changed very much till 2000. And the pace of change has really accelerated. And there are a number of reasons for that. One is agreeing the names. Another is the drug industry getting involved, and whereas previously they had never heard of vasculitis. So I'm just going to give you a few examples. And why this is important is because these drugs are directly helping patients, or will directly help patients feel better and control their vasculitis better. So the first one's avacopan, and those of you who don't like animal studies, please look away. But this is a perfect example of how valuable animal studies are to medical research. So this is a mouse that gets ankylosing, and it was demonstrated in the laboratory that it had to have something called a complement receptor on its cells for it to get the vasculitis. And if this was inhibited in some way, they didn't get the vasculitis. And a drug company came up with a drug called CCX168 here, which completely stopped. In this graph, going up is bad, and it completely stopped the animals getting vasculitis. This drug's called avacopan, and this experiment in the mouse provided the perfect sort of background to then going into patients. And the result was that we did a series of studies with the drug company that developed the drug. And then the drug got approved in America, got approved in Europe, got approved in Britain, but most important, NICE actually have agreed to for the NHS to fund it. and we had this positive decision in September last year, and it's just right now becoming available for doctors to prescribe for GPA and MPA. So again, that animal experiment I mentioned was probably around 2008, 2009. Patients will start benefiting in 2023. So time goes by, but this will be, I think this will be, again, rather like rituximab, another big advance for our patients. Now, some patients with vasculitis have this thing called Churg-Strauss, EGPA, which causes asthma, which is really, and it's characterized by an excess of one of the white blood cells called the eosinophil in the blood. And completely unrelated to any vasculitis doctors, there are a whole lot of new drugs to treat asthma. And it just so happens that some of these drugs to treat asthma suppress eosinophils. And the eosinophil is the center of EGPA. And I put the names of two of them here. Again, long names with MAB at the end. But these drugs are available. They're being used for asthma. We have tested them in Churg-Strauss, and they work. And now they're moving across into the clinic. And certainly in my clinic, almost half of the EGPA patients are now on either the first one, mepolizumab, or the second one, benralizumab. You know, it's not curing the disease. It's not completely taking everything away, but it's allowing us to get by with about half the dose of steroid that we were using before. And patients are feeling, you know, again, their quality of life is better. So we do have problems with rituximab, and so there's a lot of interest in what might replace rituximab, what might be better than rituximab, and the focus is on, I don't know how they come up with these complicated names, but we call it Obi-Wan Kenobi. Obinutuzumab is like a new super rituximab. Don't look at all the cartoon on the right, but just take away that this is much stronger than rituximab, and it may be that we just have to give this once, and it will fix patients for many years. And we just literally started, I think last month in January, we just started a trial of this new drug, Obi, in Cambridge, and there are similar trials in America and in France. So watch this space. And I think in 2 or 3 years, hopefully we'll get some data for you with Obi, and that might be an addition in the clinic. What you may have noticed is I've been talking about relatively common causes of vasculitis. And if you go back to that slide I showed at the beginning, I mentioned the two common areas, the anchor group and the giant cell arteritis group. But what if you're unlucky enough to have what we would call a rare form of vasculitis, one of the other names? There are no new drugs for them. Nobody's going to develop new drugs for them because they're very rare diseases, and drug companies won't make any money. Yet we have drugs like rituximab, and there are other drugs we think would really benefit those patients. And we had a discussion with the NHS about what to do about this, because the NHS has been saying you can't use these expensive MABs for these patients because there's no data that they work. And we were sort of going round and round in circles, and ended up agreeing to fund a trial. And this is BioVas. And this is a nice example of us telling the NHS we have a problem, and the NHS telling the government medical research agency, which is called NIHR, to try and fix it. And so what they did is essentially advertise for grants to do a trial, to put all patients with rare forms of vasculitis in one trial. So we're studying about 9 or 10 different diseases in one trial, and we're looking at these expensive drugs to see if they work. And if they do work, then the NHS will pay for them. So that is BioVas, and I'm very happy to talk more about that. So I just wanted to finish with a video, and I was going to put this under rehabilitation, which is something that we probably do not do. We tend to give the patients the drugs. We tend to be happy if they've got better, and the rehabilitation is something that we leave, unfortunately, to patients to get on with. So this is one of my patients who had really quite bad GPA, vagus, for a number of years, for many years, and fortunately is now a lot better. And she sent me this video and said, please show this video because it shows you how far my rehabilitation's gone. Whoopsie. And this is, of course, me not being able to show videos. So I'm told that was heavier than she was, but there you go. That was her rehabilitation. So I'm not the only person in Cambridge, as those of you who visited Cambridge know. I've got wonderful colleagues, and we have a whole string of visitors who come from other countries and go away again. But the most important is our nursing staff. And those of you who visited Cambridge will know Stella, who keeps us all following the straight and narrow. And I come back to what I said earlier. It's really the team and the organization that is the most important thing in terms of trying to deliver care to patients. So I'd be very happy to take any questions and talk about fertility and pregnancy.